morning, everyone. This experience is from Mumbai, although my primary unit is in Belfast. For the last 3.5 years, I've been working in Mumbai as a consultant neurosurgeon on a sabbatical from Belfast, and this is the experience purely from Mumbai. Before I start, I must thank all my colleagues, especially the endovascular colleagues, Rashmi Saraf and Uday Limay, for not only giving me permission to utilize the data and the pictures, but also helping me to prepare this presentation. Rashmi was supposed to be here, but was on maternity leave, so couldn't come. The data is from 2 centers. This is St. GS or KEM Medical College from Mumbai, one of the largest and one of the oldest medical college in Mumbai. And the other one is where I'm working, called Seven Hills Hospital and Healthcare Trust, which is one of the latest and most modern hospital in Mumbai. So from 2008 to 13, from these 2 tertiary referral centers, we've had 21 patients who have had blister-like rupture aneurysms presenting with subarachnoid hemorrhages. These were aged from 18 to 65, and there was no randomization. The setups are such that randomization is indeed very difficult. But there was multidisciplinary input before the management began, and the treatment was purely on individual merits of the cases. Most of them were grade 1 to 3 subarachnoid hemorrhage, 2 were grade 4. We did not treat anyone with grade 5. 13 had endovascular treatment, 8 had surgery, and these were from 1 to 12 days after the hemorrhage had occurred, not as early as we would have liked to, for various reasons. The reason I picked up purely blister-like aneurysms because I find they are probably most challenging and most difficult aneurysms to treat, either by endovascular means or by surgical means. Personally, I find them even more difficult than the giant aneurysms or recurrent aneurysms. The management has been fairly standard based on clinical grade, age, operator experience, available resources, which was a big factor in decisions, and patient performance and patient's expectations as well. Some of the challenges that are unique to these blister-like aneurysms are direct obliteration, either by surgery or by endovascular means, is often difficult, almost impossible, as compared to many other aneurysms. These are mostly sessile, very small. Atypical locations are common. The vessel walls are often defective, and sometimes they are just a part of starting of a dissection. They are also difficult to locate on angiograms and at surgery, and they have a higher tendency for intra-procedural rupture, both and post-treatment recurrences. These are the ways that my colleagues have treated these 13 patients, usually stent plus coil with different techniques. Telescoping stent has been used, and recently flow diverters. Surgical options, most of them we are all aware, some of them, couple of them are new. Standard clip, have used soon clipped once, have also used direct reconstruction of the vessel wall as a primary method of treatment with trapping, clip trapping. One of my colleagues has done ACAC bypass with trapping. But the important thing is, all these surgical adjuncts have to be available at your armamentarium when you undertake surgery for these aneurysms. The outcomes are not hugely different than what we would expect. 21 aneurysms treated, 13 by endovascular means, 17 had 0 to 2 MRS outcome, 4 patients perished. There were 2 intra-procedural rupture, one was endovascular, one was surgical. There were 2 deaths, again one endovascular, one surgical. And there were 2 strokes, again one surgical, one endovascular. There have been 2 recurrences so far, both treated by endovascular means. None of them have replayed. These are some of the examples treated by stent. Stent alone again, stent and coils, and flow diverters. Fairly standard nowadays in interventional practice. in surgery, I prefer to use this kind of technique, what we call parallel clipping. I find that's pretty reasonably safe than direct clipping at the nail. Sun clip has been advocated by Ed Laws and Spetzler and other colleagues. I've used it once for out of these 13 aneurysms, 8 aneurysms we treated with reasonable success. That's the post-op angiogram and the clip seen. What I would like to emphasize on that, recently Spetzler group has published a paper in 2013 and they have come up with what they call clip wrap. We know that wrapping is not effective for these aneurysms. Clipping itself is difficult. So what they have shown is clip wrapping using Teflon plate or even a patty has been quite useful and relatively easy. I have used this technique for 2 cases so far with reasonably good result and without any problems. Couple of instances where we can face in recent days now, the blister-like aneurysms. Sometimes the whole picture can be misleading. For example, this aneurysm we explored because it had an anterior communicating artery aneurysm coil 5 years ago, had rebled, and at surgery we found that the coils were almost lying outside. But what had actually bled was a blister-like aneurysm sitting there at the left A1 ACOM junction. Of course, the trick was to get there without rupturing that aneurysm and preserving the Hubners and the perforators and the Hubner on the other side. Once we identify what was the cause of bleeding, the actual treating part of it with the parallel clipping was not difficult. At the same time, we took care of the anterior communicating artery aneurysm also, which was reasonably straightforward. Multiple aneurysms and incidentally detected blister-like aneurysms are a challenge because if they are small, ideally they should be treated, but if they are thin walled where you can almost see the blood, you are almost guaranteed that it's going to rupture sometime, and then that becomes difficult. This is the right carotid. I can see the posterior communicating artery aneurysm that was bled, anterior carotid aneurysm, and a small blister-like aneurysm just beginning at the carotid bifurcation. There was also a middle cerebral artery aneurysm here. We decided to treat these two and not treat this one on this occasion because we thought the risk of any treatment here outweighed potential benefits. So to conclude, the blister-like aneurysms are difficult lesions to treat and they pose specific therapeutic challenges. Both surgery and endovascular modality have their own role to play and also have their own pros and cons. There can be, as far as I can see, no uniform protocol for these aneurysms. And as I mentioned in that surgical slide, that the treatment has to be individualized. I do not think these were all consultant-treated aneurysms, although we have a very inclination on training to undertake hands-on training at our institutes, both of them. These all cases we did not consider as suitable for training. And to summarize, despite their unique challenges, with subspecialization, outcomes, both surgical and endovascular, that can be achieved that are comparable to other intracranial aneurysms, if not better. Thank you very much for your patience listening.
Both for an excellent presentation and keeping the time. I have a question for you. If you had every possible modality at your disposal and all the possible techniques in your armamentarium, what would be your preferred one?
Preferred modality of treatment?
Yeah, endovascular or which would you give the first chance to?
Oh, usually endovascular. Yes, this has been our strategy as well. But I did not dwell because of the time. We have significant resources. The first hospital you saw is a government hospital. It takes 48 hours to procure the guide wires and catheters. So if we felt the risk of rebleeding was too high, we would have to opt with surgical clipping. But if we felt the surgery is also too risky, then we would rather wait for 2-3 days and let the time pass by and get the aneurysm coiled. So it was not absolutely on clinical grounds that we selected. But we have had no rebleeds. All the patients who waited up to 10 days, no rebleeds.
I'll just ask a very quick question. I think I like the clip wrap technique for these, they're pretty good. But I just want to ask you, have you used this for incidental aneurysms, which you can sometimes come across? Would you decide to treat them?
Now, incidental aneurysms that are detected on the MR alone or CT or angiograph, which have never ruptured, they're so small, we opt not to treat them. If incidental aneurysms are detected at surgery that you had not suspected before, then question arises, shall we do something or shall we leave it alone? So again, every case has to be individualized. The lady's case that I showed, where there were 2 aneurysms at PCOM and intracoroidal, and an incidental aneurysm at carotid bifurcation. She was 65. We decided that she had not bled so far, only 1 aneurysm that had bled. We had taken care of that and we opted not to treat it.
Any questions, please? Yes.
I'm sorry, I was a fraction late, but have you ever tried, I know it's heart-in-mouth stuff, but for the little tiny blisters, the very careful application of bipolar diathermy with irrigation, that can sometimes shrink them as long as you don't make the big hole.
Oh,
Have you tried that?
Not at all. I think it's very helpful. And actually, I tried them in most aneurysms. I did not mention them because I felt it was fairly standard, but I do try and shrink them. And the clip wrapping that I was mentioned, actually what I do is with a very low diathermy, diathermy, and irrigation going on so that your forceps don't get stuck onto the aneurysm. Yes, it's a very worthwhile coagulating it gently in the surface so that the part that would have ruptured becomes more sclerosed kind of thing, thrombosed, and then apply the clip. Yes, it is very useful. I don't think it's at all outdated. We use it all the time. Not only on blisters, on regular aneurysms as well.
But sometimes it gets rid of the blister completely, you don't have to put a clip on at all.
Well, what I've done is, once it happens is, if you don't put the clip, with the clip wrap technique that those Blizzards and guys have described recently, I find that very useful with a Teflon or even a small glove, just to wrap it around and then put a parallel clip on it. Just wrapping alone, I don't think gives enough protection. But if you wrap it and put a parallel clip on it, I think it holds it quite well.
Any more questions? Can we just move on to the next one? Could I request Mr. Choudhary to come in? Decompressive cranectomy without clot evacuation for spontaneous